Thank you, Steve, and thank you to the team here at ICOS for this opportunity. I'm one of the second-year cardiology fellows at the University of Nebraska Medical Center, and I'm here to present the article today on cardiovascular events that were seen in patients who were treated with chimeric antigen receptor T cells. This paper was published in JACC in 2019, and this was one of the major studies that looked at cardiovascular events with CAR T cell therapy, and that's the reason I chose this paper. So before we move into the journal itself, I wanted to give a little bit of a background on what are the CAR T cells. I don't have any disclosures. I'm a fellow still. So what are CAR T cells and what are their effects on the various organ systems? So CAR T cells are known as chimeric antigen receptor T cells. This is a novel concept of immunotherapy where the patient's own T cells are genetically engineered to attack cancer cells. This form of immunotherapy is being increasingly used for refractory malignancies, especially hematologic malignancies such as lymphomas and multiple myelomas as well. So chimeric antigen receptors are artificial proteins that consist of antigen recognition and T cell signaling domains. If you look at this picture, the process involves removing T cells from the host, which is a patient, and ex vivo, they are genetically engineered by inserting a gene for the CAR protein using retroviral vectors. And after that, the T cell starts expressing the CAR protein on the surface, and they are grown in millions in culture medium ex vivo, and then they are infused back into the patient's body, where they multiply in rapid quantities and then attack cancer cells. For the patient to undergo CAR T cell therapy, they have a course of lymphodepleting chemotherapy, which includes cyclophosphamide and fludarabine to deplete their innate immune system before infusing the CAR T cells to give them the best chance of attacking the cancer cells in the host body. So this is the mechanism of action of CAR T cells. It seems simple, but in the course of killing the cancer cells, it also does some collateral damage to other organ systems, where we come into this phenomenon or syndrome called cytokine release syndrome, which is one of the major toxicities of CAR T cell therapy. There is no universal definition for this syndrome, but people look at it as a systemic inflammatory syndrome involving fever, hypotension, vasoplegic state, and it's like a SIRS-like syndrome, which can be triggered by immunotherapy, including CAR T cells, and other triggers include infections like viruses and bacteria. And COVID-19 recently is also known to cause a cytokine release syndrome. In CAR T cell therapy, it's like a supraphysiologic response to the immunotherapy, which in return affects all the organ systems, including kidneys and heart. A person who mounts this cytokine release syndrome needs to have adequate cardiac reserve to support the hemodynamic derangements. It is mediated by a lot of cytokines and chemokines. In CAR T cell therapy, the major players here are IL-6, IL-10, and interferon gamma. So treatment with tocilizumab, which is an IL-6 inhibitor, seems to be effective in CAR T cell mediated cytokine release syndrome. So in this picture, we can see the mechanism of CRS, where the CAR T cells, when they bind to the cancer cells, they activate the immune system, and they also activate bystander immune cells like macrophages and endothelial activation, which releases all the cytokines and chemokines that play an important role in causing fever, hypotension, and end organ damage. There is a grading system for CRS from grade 1 to grade 4. Grade 1 being really mild with fever, and grade 4 meaning being refractory respiratory failure requiring mechanical ventilation and vasopressor support. This is a slide showing the different manifestations of cytokine release syndrome. As I said, it affects all the organ systems in the body, and the grade can vary from just as mild as a fever to grade 4 having seizures and hypotension and refractory vasoplegia and respiratory failure. Like I said, there are other triggers for CRS, including infections, immunotherapy, and some of the malignancies itself can cause cytokine release syndrome. Among infections, COVID-19 was noted to be the recent player causing cytokine release syndrome, where tocilizumab was also used in this situation. Other than cytokine release syndrome, CAR T cells were also found to cause other derangements in the body, including neurologic toxicity like peripheral neuropathy, tremors, and agitation, confusion. In the cardiovascular system, they were also found to cause QT prolongation and ST segment changes. Arrhythmias such as atrial fibrillation can also occur with CAR T cell therapy. So when we look at the prior studies that looked at cardiovascular events in CAR T cell therapy, there has not been a lot of data about this cardiovascular events. There were only like 4 or 5 studies in the past that looked at cardiovascular toxicities, and most of these studies, if you can see, they did not look at LV dysfunction, except this one study and this one in 2017. So we really do not know what's the incidence of CV events in patients receiving CAR T cell therapy, and if this is a part of the cytokine release syndrome, or if this is something like direct cardiotoxicity from the CAR T cells. If you look at this study in 2018 by Bernstein and colleagues, they did notice this was the first study where they looked at biomarkers in CAR T cell therapy, where they studied NT-proBNP and LV EF, and they followed people for about 6 months. And in this study, they did mention that the people who had LV dysfunction, most of them recovered, and there was only one patient who had persistent LV dysfunction after a year of CAR T cell therapy. So again, the background of this study is that, like I said, most patients who received CAR T cell therapy or have already known to have received some sort of chemotherapy or radiation therapy for their cancers. And CAR T cell is kind of like the last resort for refractory malignancies. So some of them could have received even anthracycline-based regimens. So their hearts are not the best to begin with. And the incidence and sequelae of CV events with CAR T cells is really unknown. And the mechanism behind these events is also unclear. Is it part of the CRS, or is it something like direct cardiotoxicity with CAR T cells, which we are just learning about? There is no prediction model, or we don't have any risk factors that are directly associated with CAR T cell toxicity. And what is the treatment for cardiovascular events or LV dysfunction? We don't know. Is this routine GDMT, or do you have to use tocilizumab and other immunomodulators? We don't have much data about that either. So the objectives of this study, they wanted to identify patients with higher risk of developing cardiovascular complications after CAR T cell therapy, and form a model for pre-treatment workup and surveillance during and after CAR T cell therapy. And the timely, effective management of CRS, does that have an effect on CV events or not? So this was a retrospective study. The authors wanted to create a registry of patients receiving CAR T cell therapy at 2 institutions, mainly at Mass Gen in Boston and Moffitt Cancer Center in Tampa, between January 2016 and November 2018. All the patients were followed up until January 2019, January 31st. This is a retrospective cohort study, and all the data was collected from review of electronic medical record and EMR codes. They did include 137 patients, of whom 4 of them were lost to follow-up. They stratified patients based on the CRS grade and troponin elevation. Statistical analysis, they used continuous variables were presented as means or median, and then they also presented categorical variables as percentages. They compared continuous data using student t-test, and categorical data was compared using chi-square or Fisher's test. They did perform univariate analysis between the time of CRS onset and tocilizumab administration to the incidence of CV events. They used SPSS software for statistical analysis. So the major outcomes and endpoints that they were looking for is a composite of decompensated heart failure, clinically significant arrhythmia, and CV death. They had unique definitions for each of these endpoints. CV death was defined as death due to heart failure, cardiogenic shock, cardiac arrest, or an arrhythmia. The onset of CRS was defined as the first appearance of fever after CAR T-cell therapy. And the time to tocilizumab administration was defined as the time from the onset of CRS or the fever to the administration of tocilizumab. This is an important point because they did find a significant difference in CV events based on this time frame. An elevated troponin was defined as a new troponin. They also used a high sensitivity troponin based on the availability at the 2 institutions. A reduction in LVEF was defined as a decrease in 10 percentage points to a value below 50%. This is the criteria they use to define heart failure event when a patient presents to the emergency room or clinic or any unscheduled visit for new or worsening heart failure requiring initiation or intensification of treatment. And they required at least 2 physical exam findings or 1 physical exam with 1 lab criteria. So this was a legit definition for heart failure. Among the symptoms, they included dyspnea, decreased exercise tolerance, fatigue, and worsening end organ dysfunction, and volume overload. Physical exam findings, they were all pretty specific for heart failure, including S3 Gallop, JVD, pulmonary crackles, peripheral edema, and among lab work, they included, NT-proBNP, radiologic evidence of pulmonary edema, and echocardiographic criteria as well. Treatment intensification included augmentation of their oral diuretics or needing intravenous diuretics or vasopressors, and sometimes some patients also needed mechanical circulatory support, which fell under the category of treatment intensification. So clinically significant arrhythmia was defined as any arrhythmia that required interventions such as beta blockades or antiarrhythmic medications or cardioversion, or any arrhythmia that resulted in cardiac arrest. So this was a big umbrella. This is the grading system for CRS that they used. This is an older grading system. Right now we have an updated grading system, which I can show later. But in this study, they used the Lee criteria, where in grade 1, it was a mild CRS with fever, and the treatment required only antipyretics and antiemetics. Grade 2 included hypoxic patients requiring oxygen just on a milder level, hypotension which was responsive to fluids, or 1 vasopressor. Grade 3 included patients who needed more than 1 vasopressor or oxygen requirement more than 40%. Grade 4 had life-threatening symptoms, including refractory respiratory failure, needing mechanical ventilation or end organ damage. And grade 5 was death. So moving on to the results, this is the table showing the baseline characteristics of patients. So the total cohort consisted of 137 patients. They stratified the patients based on the CRS grade, grade 1 or less, and grade 2 or more. Grade 2 or more had 55 patients, grade 1 or less had 82 patients. As we can see, in the severe CRS grade, which is grade 2 or more, the patients tended to be more on the older side, which was statistically significant. And the most common cancer treated here was diffuse large B-cell lymphoma. As you can see, the other demographics, I would like to say that this cohort was fairly healthy. Only 10% of them were diabetic, 39% were hypertensive, and only 1.5% of the total cohort were smokers, 7% CAD, 3% heart failure. So fairly maybe healthy compared to our cardiovascular trial patients. AFib was only in 13% of patients. And diffuse large B-cell lymphoma was the major cancer, followed by follicular lymphoma and then multiple myeloma. And like I said, most of these patients had received some sort of chemotherapy or radiation therapy before ending up on CAR T-cell therapy. About 79% of the whole cohort had been on anthracycline-based regimens previously, and there was no statistically significant difference between the two groups in prior anthracycline exposure. Echocardiographic parameters were not significantly different between the two groups either. So when they stratified the population based on troponin elevation post-CAR T cells, this is what they found. Troponin was measured only in 53 patients, which is 38% of the total cohort. This included both groups of CRS. So 53 out of the 137 patients had troponins measured. And when they were stratified based on troponin positive or negative, they did find that grade 2 or more CRS, there were more patients who had an elevated troponin, and that was statistically significant. And the other variables were all not statistically significant except the age. Patients who had an elevated troponin were older, which was statistically significant. So the incidence of CRS of any grade happened in about 59% of the total cohort, and grade 2 or more was present in 39% patient of the total cohort, and grade 3 or more was present only in 4% of the total cohort. The median time to development of CRS post-CAR T cell was about 5 days. And the time to resolution of fever was 3 days, and the number of patients who received tocilizumab was 41%, or 56 out of the 39% that had grade 2 or more. So they initiated tocilizumab therapy only for patients who had grade 2 or more CRS. And the time frame from the CAR T cell therapy to tocilizumab administration was about 5 days as a median. And the time from CRS onset, which is the first onset of fever, to tocilizumab administration was about 27 hours. So when they stratified stratified the outcomes based on the presence of CRS grade 2 or more versus grade 1 or less, they did find that there was no incidence of CV events in patients who had grade 1 or less CRS. And almost all the CV events occurred in patients who had grade 2 or more CRS. When they stratified based on CRS grade 3 or more versus grade 2 or less, they did find a statistically significant difference in CV events, although there were only 6 patients who were grade 3 or more CRS, and the rest of them were all grade 2 or less. So this is the results in a nutshell. So patients who received CAR T cell therapy was about, the total number was 137, and who ended up having CRS grade 2 or more were 55. grade 1 or less were 82. Among the group who had grade 2 or more CRS, troponin was measured only in 31 of the 55. Among the 31 who had troponin measured, 24 were positive and 7 were negative. In patients who had a positive troponin, they had 16 CV events. 8 of them had a drop in EF. There were 6 events which were labeled as CV mortality. 4 patients had new heart failure. 1 had new heart failure decompensation, and 5 of them had new arrhythmias. In the group which had a negative troponin, there was only 1 incident of heart failure decompensation. In the group that was CRS grade 2 or less, 23 patients had troponin measured. 5 of them had positive troponin and 18 had negative. Even in the group that was positive for troponin elevation, they did not find any CV events, and that is significant. That was significant statistically. So this is a table showing the CV deaths that were recorded in this population. If we can see here, the first one was a newly reduced LVEF, LV systolic dysfunction. The second one had a new atrial fibrillation and drop in LV ejection fraction. The third one had AFib or VR, heart failure, and hypotension. The fourth one was about shock following cardiac arrest. They did not mention if this was a shockable or non-shockable rhythm, and they did not mention anything about LV dysfunction or any specific cardiac parameter. The fifth one again was a PEA arrest. It could have been due to acidosis or any other electrolyte derangement causing this. And the last one was again a patient who had newly depressed EF. So this is a kind of a summary slide where we see patients were stratified as cytokine release syndrome grade 1 or less, and grade 2 or more. In grade 1 or less, even patients who had an elevated troponin had no subsequent cardiovascular events. And in patients who had grade 2 or more CRS, who had no troponin elevation, there was only 4% of CV events, and most of them were heart failure decompensations. And those who had an elevated troponin, they all received tocilizumab therapy, and some of them went on to have subsequent cardiovascular events. About 55% of them had cardiovascular events. And this is a grading system that was used in this study. Again, there is a newer grading system now, which is more simple. So summary of the results, CAR T-cell cardiotoxicity occurred mainly in elderly patients more than 60 years old, and it was often associated with patients who had a higher CV risk profile with risk factors like hypertension and diabetes. This was all just a trend. There was no statistically significant difference. And prior anti-cancer therapy with anthracyclines and radiotherapy seemed to be associated with developing cardiovascular events after CAR T-cell therapy. There was a strong association between troponin elevation post-CAR T-cell therapy and having subsequent cardiovascular events. It was observed in 95% of patients who had cardiovascular events, and mostly it was seen in patients who had CRS grade 2 or more with a positive troponin, and positive troponin had a CV event rate of 55% versus 4% with patients who had negative troponin, and that was statistically significant. And like I said before, a patient who had a positive troponin, even with a positive troponin but no CRS, that was not associated with any CV events. The median number of days to the occurrence of CRS was about 59%, and it was about 5 days in 59% of patients, and 39% had grade 2 or more. Tocilizumab was administered in 41% of patients with CRS, and the median duration was about 27 hours. And troponin elevation happened in 54% of whom of the 53 in whom it was checked. So out of 137 patients, only 53 had a troponin check, and 54% of the 53 had an elevated troponin. 28% had a drop in EF, and all this happened in grade 2 or more CRS, and that is something to note. Overall, there was about 12% CV events in the total cohort, and all of them happened in CRS grade 2 or more. The median time to events was about 21 days from the onset of CRS. 95% of events happened in patients who had an elevated troponin, and the time duration between CRS onset to tocilizumab administration was associated with CV events. For a median duration of 27 hours, they divided patients who received tocilizumab therapy before 27 hours and after 27 hours. So there was an increased risk of having CV events in patients who were delayed to be started on tocilizumab therapy. That was statistically significant as well. The risk increased 1.74 times with every 12-hour delay in starting tocilizumab therapy. So the limitations of this study, it is a retrospective study which the registry data. EMR codes were used for extracting data and the outcomes. There was a clinically significant decrease in LVEF in about 28% of patients, but only 29 of the 135 patients had echocardiographic data pre and during the CAR T-cell therapy. Troponin was measured only in 53 patients of the 137, the total cohort, and there was no data about the global longitudinal strain or biomarkers such as NT-proBNP to kind of correlate their LV dysfunction. Also, cardiovascular events occurred only in patients who had CRS grade 2 or more. So is this something that is associated with CRS like demand ischemia or myocardial injury versus is this a direct cardiotoxicity from CAR T-cell therapy is still to be explored. There was no comment about the recovery of LV function or if they used, standard guideline-mediated therapy or other, support for LV recovery. So in future, there was an editorial that followed this paper in the same JACC issue where they had some recommendations for in future to start patients on CAR T-cell therapy. The group recommended that patients who have a higher risk of higher cardiovascular risk profile to undergo, basic workup, which included troponin and proBNP to be tested before starting CAR T-cell therapy. Some of them can, depending on their risk profile, they could even undergo a stress test, a Holter monitor for subclinical arrhythmia assessment, and for sure a complete 2D echocardiography for LV function, including global longitudinal strain, and that needs to be monitored over time during the CAR T-cell therapy and afterward as well. And during treatment, beyond their clinical assessment, the group recommended, monitoring their troponin levels and proBNP levels, and any slight increase in troponin should prompt the starting of, cardioprotective therapy with tocilizumab, and the same can be done for patients who exhibit a drop in LVEF after, CAR T-cell therapy. Also, anyone who has an elevated troponin but with no CRS, the group recommended that they could be monitored closely and no treatment was necessary in the absence of additional data. So this is kind of like the algorithm that the editorial presented. So patients who have an elevated CV risk profile at baseline, they all get an ECG, troponin, and echo, and some of them can even go on to get a stress test. And then they start their CAR T-cell therapy, and during follow-up, they're assessed with troponin and clinically for CRS, any signs of CRS, and once they start developing a drop in LVEF or troponin elevation, they are initiated on tocilizumab, and repeat echocardiograms and biomarkers are followed until the patient recovers. So that's all I have for today, and I'm open for any questions.
Doctor, how do you pronounce your last name? Sundaravel?
Yes, sir.
Hi, this is Dan Linehan. I'm in at WashU in St. Louis.
Hi.
That was excellent presentation. I'm just curious, how often do you see these patients? I mean, how often are they doing CAR T therapy in Nebraska?
That's a good question. I was just asking our cardio-oncologist here, Dr. Stone. He heads our cardio-oncology program, and I think we are still in the starting stages of CAR T cell therapy. We do have a program here, and our protocol is pretty much the same as what the editorial had mentioned. We get basic, workup, including echocardiograms, and some patients also get a stress test similar to the stem cell transplant eval. I personally have not seen any CRS patients here at our center, but again, we are still very new in the game. So,
and then, yeah, I think so at WashU, I believe they're doing CAR T therapy pretty commonly. I would say I really don't have any idea what the denominator is, but it seems to me that, if I had to take a wild guess, I would say between 50 and 100 patients a year are getting CAR T therapy. It's interesting that we are not involved that much. So I think that sometimes we get involved if they develop CRS and they get tocilizumab and maybe they don't respond all that well, and then they consult us. So right. I'm not sure we're not seeing all these patients before they get therapy, and then even if they do get therapy and they sort of get along pretty well, we're not usually involved. I mean, that's just my own personal observation.
It's Joe Carver in Philadelphia at the Ableton Cancer Center. I have a question to throw out to the group. What if you were asked to see a patient who had an EF of 30% and was totally compensated and was going to get CAR T therapy? How would you approach the management, knowing that there's tachycardia, fever, hypotension? I'd like to hear what other people have to say.
Hey, Swethika, this is Jeremy Stone. I can probably answer this question. So I encountered this recently. I had a patient who presented for a stress echo for the routine pre-CAR T cell therapy because they were 72 years old. So they just wanted because he was considered high risk because of his age, and his EF was 39% on the stress echo. And I talked to his oncologist, and the oncologist said that by the FDA package insert and as well as insurance, they won't approve it or pay for it if their EF is less than 40%. So we kind of have a discrete criteria with that you can't do CAR T cell therapy in patients less than 40% for EF. So that kind of answers that question, but potentially those patients, you could treat them, get them on ACE inhibitor, beta blocker, maybe their EF will recover. They could be candidates in the future, because this patient actually ended up getting a stress MRI just because was concerned about some occult ischemia that we might be missing. I just wanted to make sure he was tuned up as much as possible. And he had some coronary calcifications on his CT, but thankfully found no inducible ischemia. He went through his CAR T cell therapy just fine. He did not have CRS, and his EF remained stable through the entire period. So to me, that shows that patients with kind of a mildly reduced ejection fraction might potentially be safe as long as their beta blocker and their ACE inhibitor are up titrated as much as possible before getting their CAR T cell therapy. But our jobs are kind of made easier that there is a strict cutoff for an ejection fraction less than 40%, that these patients are not eligible, that nobody's going to pay for those patients.
Yeah, I think that the EF criteria are certainly one thing, but to get at whether this person could tolerate a major stress, I have always felt that doing cardiopulmonary exercise testing is a more appropriate screening for either stem cell transplant, especially with allogeneic, or, you know, I would argue in the face of CAR T therapy, because standard stress echo is probably not going to give you enough information, assuming that the EF is normal to begin with. And then the other part is that it's really the stressor of the whole situation. And you're not really looking for coronary disease, so to speak, you know, that you might see with a stress echo, but rather overall physical capacity, which is what you're really interested in. And then the other thing is, you know, if you do see these people pre-op or pre-CAR T therapy, and you follow what was in that editorial and the figure that you showed, I think generally that would be correct, except for, you know, again, I wouldn't go with a standard stress test. I would, you know, my own personal opinion would be more that cardiopulmonary exercise tests would give you more information. But then the other is the NT-proBNP really should be established at baseline, because in this report that you went over, they don't really say that data, but I know that in almost all the patients that had cardiovascular events, their NT-proBNP was abnormal at baseline. So
Interesting.
And they also, if you look at the rate or the percentage of patients that got previous anthracycline, it's quite high. So the, you know, the previous diagnosis of lymphoma that is in remission, you know, they probably got anthracycline for their lymphoma treatment, and now they have recurrent lymphoma. So these are really high risk patients, I would think.
Yes, you're absolutely right. There were about like 70% of the whole cohort had received anthracyclines and even other forms of chemo and radiation therapy too. So yeah, they're not healthy to begin with.
And, you know, I think that, I guess it's part of it is, you know, how much are the oncologists willing to handle before they get you involved? And, you know, I think our observation is that the oncologists are willing to handle a lot. I guess they're used to dealing with complex medical issues post-transplant, so they don't really get us involved until the shit really has hit the fan.
This is Isaac Ray calling from Memphis, Tennessee. So we've had a few patients out here that have had lower EFs, and maybe it's dependent on the type of CAR T treatment that they use, but they're usually not that afraid. That being said, I don't think we've ever tackled anyone less than 35%. Yeah, we will still follow them fairly closely. But so far these patients have sailed through fairly well. We just make sure to optimize them, and they usually have pretty good functional status going into it.
Yeah, no, thank you, Isaac, for your comments. I know you were an author on the paper, so I think that you have obviously had experience. I guess it was mainly at Moffitt where you were before.
That's correct. Yeah, I mean, but when I was at Moffitt, this state already collected all their patient data, but it was still an interesting study to help put together.
Yeah, no, absolutely. Well, this has been really great. Thank you so much for going through these details. I think that it's, you know, I generally would want to be involved in what I would consider high-risk patients, but you know, it's also, you have to work within the context of the oncology team that you work with day in and day out. So if they don't feel uncomfortable about giving this therapy, then I guess we can just say we'll be engaged whenever you're ready for us. But I think that most of these patients have gotten a significant amount of anthracycline. They're pretty high risk.
Dan, I think Avi Guha had a question or comment.
Hey, thanks for asking. Dan, I think one thing which you said about sort of having oncologists involve us sooner. So at UH, there's a protocol for sort of screening everybody who comes in for a stem cell transplant. So what has happened is the stem cell transplant has sort of the SCT and CAR-T somehow, I think, mixed together for some reason. But we do get all the CAR-T patients get screened in similar way as stem cell transplant. So which essentially is similar for what we do, except I think the post echocardiogram happens a little sooner.
Yeah, I think that, I guess the other question is how quickly or how soon after CAR-T therapy would you go with tocilizumab? At least based on this report, they're suggesting that the time from the onset of CRS to initiating tocilizumab is actually the shorter that time is, the better the patient does. So
I think this is an impatient situation, right? Because I think what is happening is it's almost like the door to balloon time situation where the patient has CRS happen, and depending on the grade, the sooner you give tocilizumab, the better it is. It'll probably be similar to how the giving of steroids happens in patients with checkpoint inhibitor myocarditis. I guess that has to be studied in multiple cohorts. This is only one cohort, but I would say that's an inpatient thing. Obviously, we don't get involved in that yet. So, but I think that's a good question to sort of study again.
Yeah, so it's Joe again. Dr. Stone mentioned the difference in CAR-T preparations, and in people who have some cardiac potential for toxicity, that yes, CAR-T is probably better than Kymriah from the standpoint of the incidence of CRS. So the choice of CAR-T does make a difference. And then just I have a different interpretation of CRS, and it can't remember to schedule a cardio-oncology appointment.
all right, well, there you go. That's the word from Penn, right?
And Janet Selly. Janet is a nurse, and I should have said at the beginning of the call, it's, at least in our country, National Nurses Day. So shout out to all our nurses. Janet had a comment or question.
Thank you so much, Stephen. Thank you so much for this excellent presentation. I was just curious, of the CV deaths that were studied, I know you said it was a retrospective study looking at the computerized data, but when I was looking at the slide of your deaths, most of the folks were over 50 years of age, 60, 70 years of age, but the 39-year-old that I had viewed, yes, thank you, that's it.
Yes.
Did that patient have an excessive amount of anthracycline? Was that just an outlier, or was that particular patient somebody that was recognized as having CV risk factors prior to this data being collected? I was just curious.
Well, that's a really great question. The age certainly seems to be a young patient. I'm not sure about what the baseline characteristics were about these CV death patients. I did not come across that, but certainly, yeah, those seem to be, he might have had radiation in the past, and some of it could have been radiation induced. I'm not sure really.
Indeed, yeah, that just stuck out at me. I was just curious, but thank
Right.
you so much. It was
He
a
didn't
great
mention
presentation.
heart failure or LV dysfunction either on him, so I'm not really sure what made him be included as a CV death.
Okay, appreciate it.
Sure, thank you.
Great. So, Jose, I don't know if you have any other comments in regards to, have there been any other papers that have, tried to address these issues? I know this one was a fairly definitive retrospective study, but I don't know if there have been any more recent publications that provide different insight.
Not that I'm aware of right now. I mean,
yeah, so I think that this therapy is still being developed in a lot of places, and I don't think it really applies, and certainly it's not going to apply in a underdeveloped country because it's so expensive. The cost of CAR T therapy is somewhere in the range of $400,000 to $500,000. So it's an expensive option.
Prince, did you have a question or comment?
the only thing that I was going to mention is that about the LVF recovery. That's pretty interesting. I mean, we've had patients that we have been consulted for nearly depressed ejection fraction after CAR T therapy, and within 48 hours, 72 hours at the most, their ejection fraction has recovered like from 20s or 30% back to their baseline after receiving the tocilizumab and other supportive treatment. So it would be nice in the future to, I think this was not particularly addressed in this paper about the incidence of LVF recovery and how much it takes to see an improvement in ventricular function after initiation of treatment for CRS.
So sorry to interrupt. There was this one study in 2018 by Burstein. I'm not sure where this was from, but they looked at LV recovery and they did use GDMT for patients whom they found LV dysfunction in. And they mentioned that at 6 months, they didn't say the timeline of recovery. At 6 months, there was only one patient who was left with persistent LV dysfunction. So to your point, I think there is a good chance of LV recovery in these patients if they're treated adequately well.
Yeah, I mean, and yeah, hopefully that's the case because it's something transient and it's something that is most likely stress-induced and stress-related. So just like any other stress-induced cardiomyopathy, we would expect it to have a recovered LV ejection fraction if the patient makes it through and there's no other complications such as sepsis or things of that nature.
Yeah, I think one of the difficult clinical questions that always exists is, once these patients get CAR T therapy and then they develop LV dysfunction, whether or not they had profound CRS, you have to entertain the possibility that they have some sort of myocarditis. So then you're sort of in the middle of a very difficult differential diagnosis. And so, at least for CRS related to CAR T therapy, most of the time, we don't really see that there's a benefit of corticosteroids. Whereas in certain types of myocarditis, there may be. So, this is a very challenging evaluation.
And the other point, I don't know, Dan, if you remember, and I don't know the experience of other places that do a lot of CAR T cell therapy. In terms of the timeline of developing CRS, at least we had one patient that it happened more than a month after they got the CAR T, and the oncologists were baffled by the timeline. And I don't know if anybody else has ever had a patient that present with CRS from CAR T cell therapy, beyond 30 days of administration.
I haven't had one beyond 30 days. We have seen at UH actually a number of transplant patients will transiently drop their EF and then recover. But I haven't seen enough CAR T patients and looked at those specifically to see if this occurred with them as well.
Yeah, I just think, we're very early in our general experience, especially, as cardio-oncology supporting these patients. I think, only major institutions right now are doing this therapy on any kind of routine. And so I think we have to keep having presentations like this so that we can learn from each other. But right now we're all sort of on the job training. Great. Well, thank you all so much, Dr. Sundaravel and Dr. Stone. This has really been fantastic, and we're certainly glad to hear that you guys are trying to be proactive and be involved, and that's really great.
Thank you.
Great job, Swethika.
Thank you.
Yeah, very excellent. Excellent.
Nice job.
All right. So Steve, I think we have another presentation next week. Is that correct?
We do. We have a case review coming out of Ohio State University on TKI-associated cardiotoxicity in hematologic malignancy patients. So that'll be excellent.
Great. All right. Well, thank you all so much. And again, thanks for a great presentation from University of Nebraska. Really awesome.
Yep. Thank you all so much.
Goodbye.
Thank you.
Bye.
Thank you. Awesome presentation.